a minute after 1. It's a little after 1, so I think we've got a lot on the on the agenda, and so want to be cognizant of people's time. So again, just want to say welcome to the Alliance All Provider meeting for June. Just a couple of quick housekeeping items. What the plan is that we are going to ask folks to put their questions in the chat, but we are going to, if there's questions related to the speaker that just finished, we're going to go ahead and ask those questions while the speaker is still available throughout the presentation. So instead of waiting until the complete end to ask all the questions, if we do get to be in a situation where we're running out of time, we may have to put a hold on the questions and revisit them at the end, and then whatever we can't get to go ahead and post to the website. Also letting folks know that we will have the recording, and the PowerPoint will be posted on the website no later by this time next week. I'm sure it'll be sooner, but it'll be at that point. So again, want to say welcome, and would like to go ahead and go to the first part of our agenda. And I'd like to welcome Rob Robinson. For those folks that don't know, he is the CEO of with Alliance Health, and he is going to go ahead and give an update on the Mecklenburg County alignment. Rob?
All right, thank you, Kathy. And good afternoon, everyone. I hope you're all doing well. We'll take just a moment. In just a moment, I'll talk about the County LME MCO realignment. But since this is the first time I've been before you in a while, since our world dramatically changed in March of last year, I do want to take a minute and take this opportunity to state that on behalf of all of us here at Alliance, we want to express our sincere gratitude to each of you for your partnership during the last 15 challenging months. You guys have been true professionals. You've shown great flexibility and resiliency, and most importantly, stepped up to ensure services were delivered during really the worst of times. So, really great work, and please be assured that your efforts are recognized and greatly appreciated. Thank you. All right, on the county realignment. So let me talk about Orange County. I think you may know we've been working with Orange County for several months now on their interest to disengage with Cardinal and realign with Alliance. The county has gone through the process outlined by the state. You may be aware the state, if a county does want to disengage, they can make that request. There's several hoops that they need to jump through in order to do that. The county has done all of that. The packet has been sent up, and now it's waiting approval by the secretary. If and when it is approved, I don't expect that she won't approve it, but I don't want to get ahead of ourselves. She does have the authority to say yay or nay. If she says yay, we plan to go live and take on care for Orange on January 1st of 2022. Next is Mecklenburg County. Again, you may be aware, it's been in the news for a couple weeks now, but on June 1st, Mecklenburg Board of County Commissioners voted to disengage from Cardinal and realign with Alliance. As a result of this decision, not speaking for Cardinal, but essentially they determined that they can no longer sustain in its current form. They have made the decision to consolidate with Via Health, who is out west. They have set a June 2022 as the official consolidation date. So this question has come up a couple of times. Cardinal is still responsible for care up until the merger date or consolidation date, which again, they're planning on June of 2022. We are working with Mecklenburg County to work through the state defined county disengagement process. Again, it's the same process we went through with Orange. Mecklenburg has been pretty proactive and have already gone through several of the needed steps. In response to this, the state has met with the other Cardinal counties. Again, counties typically, based on legislation, do get choice in where they want to land. So the state has met with the counties that are all, I think all 19 of them, and they had stated that they can either remain with Cardinal / Baya, or if they want to choose another LME MCO and they do not want to go with Baya, they have the opportunity to do so right now. The state has asked that they give their submission by the end of June. And I know there's a lot of work being done around that, but that's the game plan around Mecklenburg. So on the Mecklenburg timeline, you will see June 1st, the Mecklenburg voted to disengage. June 29th is a big day for us. I'll be seeking board approval for a resolution. The resolution essentially says that Alliance agrees to get Mecklenburg County into the Alliance catchment area. On September 6th, the request of the packet will be sent to the department by Mecklenburg County to disengage. Secretary has a deadline of December 4th to say yes or no, whether or not she agrees with Mecklenburg joining Alliance. I do expect to be sooner than December 4th, but that's the deadline. And then we are planning on April 1st go live in MEC. I do anticipate also that date to be sooner, but more information is needed, and we'll be working with Cardinal and Baya on the best way to take it, on the best date to move forward. So I do want to share with you how we're going to handle the realignment. We're going to do this in 2 phases, and I think this is important for those providers that also work in MEC. First is phase 1, which is now we want to work through with the county on the disengagement process for the go live date of April 1st or sooner. At go live, our initial goal is ensuring this system stabilization at realignment, right? We want to prevent any disruption to services. So our goals are very simple, right? We want to hire staff that we need to hire to serve MEC. We want to make sure members are seen and providers are contracted with and providers are paid. That's what we plan to do is phase 1, and that is work we will be focusing on up until we go live. Phase 2 will be what we do in all of our counties. We will work with the community, with providers to evaluate services, determine what the gaps are, and make a plan to improve services in that community. So that's more the longer term. What you can do to help us out is to really make sure to set realistic expectations around this. Again, if you work in Mecklenburg, that you understand and recognize, and I think you would, that let's do phase 1 first, make sure that we're operational, and then we'll set longer term goals. I'm working with the community, and they've been very receptive to hearing that, you know, we're not going to be able to solve all problems immediately. So a couple of other expectations on services in Mecklenburg County. Please, I'm going to say a couple of times, these are draft, but I do want to make you aware of things that we're thinking about if you are working also in Mecklenburg County. Again, our intent is to ensure a seamless transition from Cardinal to Alliance, preventing disruption in services. So to achieve this goal, we agree we will bring in to our network providers who are serving members in Mecklenburg County that, one, are in good standing with Cardinal and Alliance, and of course meet all the applicable state imposed rules and requirements. So if you're serving members now in Mecklenburg, you're in good standing, we would love for you to be part of our network. We're also trying to work on getting approval to expedite the credentialing process. Basically what that means, we want to be able to accept Cardinal credentialing. I know credentialing is a challenge for you as it is for us. If we can eliminate that step, I think that would bode well for both of our organization and of course the members as well. Rates are another issue I know are important to providers. So what we are honoring, what we're going to say right now is we will continue to honor Cardinal's base rates as of December 31st, 2020. So going back to December 31st, I know there have been some substantial rate increases. I understand why Cardinal did it. we cannot guarantee that we can honor all of those rates. So what we do agree to is to go back to December 31st. Again, all of this is dependent upon our rate negotiations with the state, both for Medicaid and state dollars. But please hear me. We don't want any disruptions. Any rate changes we know will have an impact on services. We are going to do our best to at least honor. And then as we move forward, we'll continue to evaluate and make any changes that we need to. And then the last thing is at go live, we'll make every effort to honor all the existing service authorizations and any members' individual support plans. So that's it for the update. I would be happy to entertain any questions. And before you ask, I'm afraid probably a lot of my answers are going to be, we're not sure yet. We are very new. This has moved extremely fast. I think our staff just learned about this, about a week or two ago. So we are working as fast as we can, but I would like to hear your questions to make sure that we capture those and that we address it as we plan this out.
Okay, Rob. The first question that we have is a question, just I think verifying rates from December 31st, 2020 forward will be honored.
Yes, December, what did I say now? December 31st, December 31st, 2020 is the date that we'll honor at go live.
So not necessarily, I think there's an important distinction. So that the question was, would the rates from December 31st, 2020 forward be honored? And I think what you're saying is rates that were in place on December 31st, 2020 will be honored, not ones necessarily past that date. Is that what you were saying, Rob?
Yeah, okay. Thank you, Kathy, for clarifying that. Yes, that is correct.
And the next thing is just a comment. I know Mecklenburg will be pleased with Alliance's reliability, leadership, and responsiveness to high quality treatment, foster, and kinship care services.
Thank you. We hope so.
And that's all. Well, here's one more. Will you be accepting new providers out of network? Cardinal and Alliance.
Yeah, that's a great question. So the answer to that is going to be determined. Like anything else, we will evaluate what's in the network and actually speak with the providers as well about a need to expand the network. If we determine a gap or needs a need to expand, we will do that, but we don't have enough information about the network. I do know, just based on reading in the newspaper that their Cardinal has made an effort to expand the network based on a request that it was too narrow. So we want to see, I know they've done some things and we will see what that looks like. And one comment related to that. So I've had multiple conversations with Cardinal and I do appreciate they understand the situation they're in. And what I appreciate most is they do want to make sure this is as seamless as well. So at this point, they are committed to working through this.
Cardinal's December 2020 rates are higher than Alliance rates, and that's a question. And will Alliance provider get an increase for continuity?
So we'll evaluate that. Again, I know Cardinal as of recently increased the rates substantially. A lot of what we'll do around rates, what I want to commit to is the December 31st rate and then determine what money we get from the state. If the state pays us the higher rate, then we will do our best to try and honor any additional rate. I do know that some of that rate was related to the one-time COVID money, and it's not sustainable for the long haul. So I want to be crystal clear with that and not pull any punches around this. We will do what we can afford and what we're paid by the state for rates, but know that anytime we can pay you a higher rate because it's in our money, we will do that.
Okay. And then we have an additional question regarding rates. If we already have a contract with Alliance, would those be the correct rates or will the Mecklenburg County clients' rates be different?
So you broke up a little bit. So if I think I heard the question, if we've got a rate with Alliance or a rate with Mecklenburg, which rate will we choose? I guess is what I heard. If I got that wrong, please tell me. That's a darn good question. I would say, I probably shouldn't speak, but I'll say it anyway. I think we would honor the Mecklenburg rate. If that's the rate that you're being paid now to serve in Mecklenburg, if the Alliance rate is lower, we would honor the Mecklenburg rate. Again, all contingent upon making sure we get the money from the state on that. But that would be our goal.
Yeah, and Rob, I think probably we'll have to do some clarification down the road is if we have providers that are statewide, and so they've got their Mecklenburg County members are serving, and then they have our current Alliance members. So would their rates for the current Alliance members be the same as the Mecklenburg County member? So the same company, but different catchment area, different counties. Are we going to have a rate difference between the counties?
Good point, Kathy. That's one we'll have to take back. And good question.
Okay.
We got to figure that one out.
Yeah, and that was part of the questions that they've asked. And it looks like there's some additional, like, real specific questions with rates. So my recommendation would be for us to look at those individually. They're getting into the individual rate questions, like for specialized consultative services and that rate structure, unless you want to answer those, Rob, but.
very, very kind of you to let me talk.
My recommendation would be let us to look at.
Thank you.
Yes, to look at those individually. Does anyone else have any questions, additional questions for Rob?
All right. Thank you, everyone. I appreciate your time.
Thanks, Rob, for coming. That was very helpful. All right. Well, so let's go ahead to our second area where Dr. Menkat is going to talk about the transition of care with the standard plan launch coming up within days. Weeks.
You got it.
2 weeks. So I'll go ahead and turn it over to you. Sure.
Yeah, happy to be here. So I'm excited for one reason and terrified for another. So excited to be here and talking about something other than COVID. So that's awesome. And I guess now that I've mentioned it, I have to say one sentence. The numbers in North Carolina in terms of the daily case counts are better than they've been in over a year. We're now down to numbers like we saw just in the first few weeks of COVID. And so thank you all for recommending to the people that you serve that they go ahead and get vaccinated. We still do have a lot of vaccine on the shelf in North Carolina. And as you know, it's free for anyone to receive age 12 or older. And so if you interact with folks who are not yet vaccinated, please help them understand their options. And for those who are either homebound or have difficulty getting to a vaccine clinic, there's now mobile vaccine support. And so that's kind of a county by county effort. And if you have questions about that, email me separately and I can actually help you get connected. Sorry, Kathy, I mentioned COVID and it just kind of spilled out of me. So
that's okay.
All right. I just wanted to spend, and this is the part I'm terrified about. So I am not the subject matter expert for transition of care. Our two people that are the true experts in this stuff are unavailable. So you're stuck with me, and I'll do my very best to explain to you what's a fairly rapidly shifting landscape for transition of care, which really is highlighted in this slide and the next. It's this idea that, right now, Alliance covers about 269,000 people in 4 counties in North Carolina. And on the date of July 1st, most of those people will be moved to standard plans. And all of that, obviously, as you know, is well underway. So about 234,000 people will be moving out of Alliance and into standard plans. And so we will keep, during this transition year, 35,000 folks who are going to be in our tailored plan anyway. And at some point, we'll be adding on the Orange County folks and the Mecklenburg folks, again, who are tailored plan eligible individuals. The piece that's different about this slide as compared to what I was planning to say, so what I learned just in the past week and a half, is that the state made a decision, which I agree with, that if an individual is tailored plan eligible, we need to pause on moving them anywhere and keep them in the LME MCO system for a few more months, just until the go live of July 1st passes. And the main reason for this is that there's been some confusion, and some individuals and their guardians who are tailored plan eligible and receiving so-called enhanced services from you all have signed up for standard plans, and those enhanced services, whether they're MHSUD or IDD services, are not in the benefits package for the standard plans. And so those folks were in jeopardy of losing their benefits. And so the state made the decision to kind of reverse course a little bit with those individuals and keep them in the LME system a bit longer. There are outreach letters that are going on. If they have questions, they can call the enrollment broker, and there's a script that'll be read to them about this to help explain. And if they really truly do want to leave the LME MCO system, give up their enhanced services benefits that they're currently entitled to, they will be able to do that, but that's going to be in a few months. Next slide, please. So we're going to go from a one-directional arrow to two directions. So once we're past July 1st, so I guess it'll be July 2nd, individuals will be moving back and forth between the LME MCOs and the standard plans. So in the state of North Carolina, we'll have about 2 million people in standard plans, split between all the different plans and between all the different parts of North Carolina. And if someone ends up in a tailored plan defining situation, let's say they've had 2 hospitalizations or they get a certain diagnosis or what, then they're eligible to be moved back over to an LME MCO, and in our case, it would be Alliance. And so this is something that we're preparing for after July 1st. Next slide, please. So there's kind of 2 components to this transition of care process, and some of you attended a state lecture on transition of care, and it was, if you've been to it, it's like an hour long and has like 40 slides. We thought, by the way, that this 10-minute summary might be helpful to just kind of have a high-level view of everything. But you might have seen this before. Most of the movement of individuals in terms of their payer source is done electronically. And so there's a massive data exchange between all of the LME MCOs and then the state moves the folks into the standard plans. And so that process it has been built over the past year, and it's right now, and sounds like it's going okay. For a very small number of individuals, there's actually a more personal touch, and I think that's on the next slide. If we could go to the next one. All right. Yeah, so this is what's going to happen, or is actually underway right now for a small number of individuals. We think, out of that 200,000+ folks that are moving over to standard plans, about 200 of them, so a very small number, actually need what's called a warm handoff. And so if those of you have had experience with nursing shifts or kind of working in hospitals, this is where one team gives a report to another team in a very kind of structured way, in this case through warm handoff summaries. And so I can share with you that we've already had contact with all of the standard plans and have begun these batch communications of warm handoff summaries, and our experience in terms of providing the information is that it's gone quite well, and that the standard plans have been very receptive. And then after July 1st, it's going to be kind of bi-directional, where, you know, if a member needs to move over to a tailored plan, or sorry, an LME MCO for the next year, then they'll contact us and provide a similar sort of warm handoff. Next slide, please. And just wanted to mention a little bit about This probably matters to certain who are watching. And Kathy, I'm hoping that we'll have these slides for folks to take with them. Is that right?
Yes, it'll be posted on our website.
Great,
for folks
great.
To get,
So,
yep.
so I'll kind of speed through this. What you'll probably want to do as you get closer to kind of having this question in your mind about prior authorization is go back to these slides. You can certainly call us. You can talk to the state. There's, you know, plenty of places where you can get information, and in some cases it'll be information that you'll be getting from the standard plans. But you know, the short version is, please keep submitting your service authorization requests to us. Even if the person is headed to a standard plan on July 1st, submit them to us up until 11:59 p.m. on June 30th. And then we'll take care of sending the the authorization over to the standard plan if we get it before then. If you have a person who you're serving and you need to send in an authorization request and it's after that date, so basically July 1 onwards, we'll only look at the ones for retroactive dates of service, and that should make sense. The other piece to know is that if someone has an open and active authorization with us, it will port over to the standard plans, and they will authorize, or they will accept it for 90 days, and then you'll have to work with them. Let's see. Oh, the last bit I wanted to mention is this you know, tricky piece with confidentiality and 42 CFR, which mainly impacts substance use disorder information and moving that from one place to another. And it has a few other components as well. But if the work that you do is protected by this federal privacy regulation, which is pretty strict, then you know, we would need a release of information from the member in order to send it over to the standard plans. Next slide, please. If you want to look in NC Tracks, you can actually find out 1 month in advance where a member is going to be or where a North Carolina person is going to be getting their Medicaid service from, whether it's from an LME MCO for behavioral health and Medicaid Direct for physical health, or whether it's from a standard plan. So that should be available for you to view right now. If it's not, hi.
And actually, I was going to talk about that also in my presentation, so we got that covered.
That's a state question. I'm pretty sure this is the last slide, but Kathy, do you want to just make sure? Yeah. All right. Any questions I can try to answer for you? Okay. Well, good luck with the transition. As you know, we're always here to help. We'll try to answer your questions. If they get a little too detailed about the standard plans, you probably want to start with them. But if it's about Alliance stuff, then we are happy to support you.
Great. Thank you very much. I appreciate your presentation. All right. So we'll go ahead to the next one. So I'm going to go ahead and do a little presentation. Amy, if you can go to the next slide. All right. So you'll see this resonating throughout our presentations today. So the go live for the standard plans is soon, effective July 1st. Medicaid managed care starts. And we just wanted to hit on a couple of high points just as reminders. Providers will need to ensure that they're aware of which standard plan their members are assigned to. For members that are transitioning to a standard plan, billing beginning with dates of service July 1 will need to be submitted to the member's standard plan. And I really wanted to highlight that because we have heard from some billing entities that they're just planning on submitting all their claims to Alliance or all the plans. Please don't do that. Please ensure that you are submitting your member claims to the health plan that member belongs to. And so you're going to want to ensure that you have contracts with those plans. But I really want to discourage folks from just sending them to all the plans and hope that one hits. That it's a lot of administrative work for yourself as well as for all the plans. Next slide. So, and we went in and checked this. So there is a process that you can go in and verify your member's health plan. And again, this will be available to you, but you can go in through the NCTRACS provider portal. You sign in, you go to eligibility and inquiry navigation. You populate, for your information, the recipient and the time period information. So when we tested this, what we did notice is if we put in an effective date starting like June 16th, you're not going to get the information for the standard plans. So you're going to definitely want to use the effective date of 7/1/21 or after, depending on when you check. So to go ahead and do that, and then it clearly shows you what plan that member is enrolled in. So just would want people can start doing that now. It is live. It is a system that is live. So that is going to be your most up-to-date information as to the eligibility verification. Next slide. So, but one thing we did want to, because I am not aware of if there is a way that you can get all that information from NCTRACS, so you don't have to go in and put in individual names. That is something that we'll ask, but it would probably be also something that you might want to ask of NCTRACS because it's their system. But we have developed a report based on paid claims by provider that identifies Alliance members that are identified as tailored plan eligible by service usage. So if that is something you'd be interested in getting from us, we're going to ask you to email providernetworks@alliancehealthplan.org and request a list of the members that meet the above criteria for their agency. We'll be sending an encrypted email. But I do want to say that this data is limited by paid claims and is only valid at a certain point of time. Again, it's not something that's a live thing as of right then. It's just as valid as when we pull the report, when NCTRACS updates, and when you have a paid claim. But we are willing to do that. If folks want to go ahead and request that. But we really, for the most current and accurate information, really recommend that you verify the eligibility via NCTRACS. Next slide. And we wanted to put this slide is just, again, resources that want to encourage folks to go ahead and bookmark and use. I have to admit, I'll go in and look at this. This is where I find some of information that we can help with letting folks know what's going on. This quick reference guide that I found, and this is the link in order to get it. It's it goes into how to verify. It gives all the contact information for the standard plans for claims, authorizations, non-emergency medical transportation, etc. So it's I think it's a 1.5 page reference. But I just would recommend going in and continuing to browse that just to get up-to-date information. And the state does update this on a regular basis, is what I found. So just want to encourage reminding folks about this. Okay, next slide. Okay, so that was it for me, but is there some questions?
Yes, we do have a question.
Okay.
Does each plan have the same authorization process?
So that is, you're going to want to contact the health plans to talk to them about their authorization process.
Okay. And then when verifying eligibility in NC tracks, I see the payer changes from Alliance to their new PHP. However, their policy number does not change. Are policy numbers staying the same regardless of PHP or LME MCO?
So if you're saying policy number, meaning the member's Medicaid ID number, those numbers are staying the same.
Okay. What is the date that there will be no movement from Alliance to PHP? Do we need to keep rechecking up until July 1st?
So you are as you are currently responsible now, are responsible for verifying your members' Medicaid eligibility. And that is only going to help you to continue to make sure that you are submitting claims to the right payer. So you are going to want to continue to do monthly verifications like you do now to ensure, again, that's kept up, because it is fluid. There could be members that become tailored plan eligible that are in the standard plan. There's also the period where folks that were tailored plan eligible, but would have potentially gone to a standard plan that came back to the LME MCO. They could go back to the standard plan. I believe it's a 90-day period. So you're going to need to recheck for every month. I'm just going to say forever. And again, that's sort of what I would anticipate most agencies are doing anyway, because you would always want to check to make sure that your member's Medicaid is still valid. And this time you're not only checking is the Medicaid still valid, but what plan is that member registered with. And also when the member comes in, asking them, because a lot of, if in the future, when folks, if they're choosing to switch plans, they would be part of that discussion. So would they change from June 28th to June 30th? Again, because there's a lot going on. It could change from June 28th to June 30th. I mean, I don't know what the percentage is. If it's you'll have to make that business decision, the risk that you want to take with that. But at this point, and Sarah, I don't know if I don't know if someone's in a plan for a full month starting July 1, whether there could be some changes that start. So that one I'm not 100% sure of if the start date would be after the first of the month or in the middle of a month.
Yeah, so I think when we're talking about this, hi folks, good to be here with you all today. Sarah Wilson. I think I know most of you all. So I think while we're thinking about this time period before the standard plans launch, which is obviously on July 1, the biggest population where we're probably going to see the most movement is some 7,000 individuals that Dr. Mank had referenced as part of his presentation that are tailored plan eligible. They've been identified tailored plan eligible, but for whatever reason, misunderstanding, miscommunication, they decided to select a standard plan. So all of those folks are being moved back by the state. And so they're coming back into the LME MCO, Medicaid Direct on the physical health side, and they are flagged essentially in tracks as tailored plan eligible. So that's really the movement that's supposed to have already occurred for the most part. I think they may be finishing some of that movement up this week to get those folks back to the LME MCO system. But as we think about life after July 1, essentially kind of July 1 is what the department refers to as managed care launch. When we get past that date, everything after that date really becomes ongoing transitions of care. And so what that means as far as someone's eligibility status, if somebody needs to move urgently because they have a need for a tailored plan only service, and they are otherwise enrolled in the standard plan, what the department has said is that those individuals would essentially be moved. Their eligibility status from standard plan to tailored plan would potentially be moved middle of the month based on the date that service associated request was submitted and processed by the enrollment broker. Otherwise, if someone is moving between plans, standard plan to tailored plan, and it's not kind of under that urgent situation, which is really the fact that they needed to utilize a tailored plan only service, then it will be the effective date of the month following. So as really we're kind of in this bit of an odd window while folks are moving back and forth from standard plan back to the tailored plans, but moving forward, it will become a little bit easier to predict based on the date that a service associated request was submitted to the enrollment broker. That's when the eligibility status would change. Otherwise, if somebody moves, it's going to be effective the first of the month following whenever the request was made. So I don't know if that helps at all.
Great, thank you. Will Alliance get a copy of clients on the list of the 7,500? I know it was requested, all the MCOs did ask for that list. I don't know if we've gotten an answer yet, if we would be receiving that particular list or not.
We have not received that yet. The LME MCOs were supposed to get that information and we have not received that yet.
And then wondering if transition auths would be available prior to July 1st, or will we need to wait on that? I don't know the answer to that. That may be something that we'll have to follow up and we'll answer back in the chat. Okay. Well, great. Well, we know this is a big transition time. And you know, always feel free to reach out. We may not be able to, we may not know the answer right off, but we will work to be able to get you the answer the best that we can. So feel free to reach out. All right. So I'm going to go ahead to legislative updates and get Sarah back on the line.
Okay, thanks, Kathy. Good again to be with you all today. So Amy, I think you're driving. If you could advance me to my one and only slide. So wanted to give you all a quick update on where we are with the state budget. Some of you are probably aware, you've probably read in the news, the House and the Senate have agreed to kind of a bottom line number in terms of a total budget, which is about $25.7 billion that they've agreed to in spending for this next biennium, which would be fiscal year 21-22 and then fiscal year 22-23. That is, you know, it's an increase from current spending by about 3.45%, but it is still lower than the governor's budget that he has proposed. His budget was about $27.3 billion. So there's a little under a $2 billion difference between what the governor is proposing to spend in his budget and where the House and Senate have agreed to in terms of that bottom line number. The big piece, it may feel a little bit like Groundhog Day because I think where we'll see the biggest impasse again is the fact that the General Assembly budget still does not include Medicaid expansion. And as you all know, that is a big priority for the governor and really what the issue was last session in terms of them really being able to agree to a total state budget. The Republican Senate and leadership would really like to see some tax cuts in this budget. And so while we don't necessarily know what all of those look like, yet that they are saying that they have proposed as part of their budget tax cuts in this next in their budget. So in terms of kind of what's next on this, The Senate is aiming to have their budget released by the week of June 21st. And then that would allow the House, theoretically, the time and the opportunity to get their budget, their version of the budget done by mid to late July, possibly early August. As you all are probably aware, kind of the goal, unofficial goal is for the General Assembly to have a budget kind of in place and submitted to the governor by the 4th of July. Obviously, with these dates that we've just talked about, that's not going to happen. So they have agreed to hold sessions the week of July 5th, but there will be no vote sessions, so they won't be taking votes on anything that week. And then once the Senate and the House have their version, obviously, you know, you all have been around long enough to know that they're not going to align, so they'll have to conference those. And so they are anticipating conferencing on their budgets for about 1 to 2 weeks after the House finishes theirs, with the intention of sending it to the governor. And then, of course, we're tracking that, and we'll have to see how that plays out again, knowing that it's not likely going to go to him with Medicaid expansion included in that. So before I switch to a couple of bills that I wanted to point out to you all that I think may be of interest to you, does anybody have any questions on the budget piece? Okay. So a couple of individual bills to point out. There's several bills that have been introduced this session, which target some of the issues and concerns around the rate of pay for direct care workers. And so Senate Bill 615, and when Kathy posts these, or when these get posted to the website, these will be working links. So the links will take you right to the legislation. Senate Bill 615 is a direct care worker wage pass-through for Medicaid. It was filed in April, and for that particular bill, it applies to Medicaid or state plan personal care services, Cap C, which is a waiver for medically fragile children, and then Cap DA, which is a waiver for fragile adults with disabilities as well. What this would do, it would be a 15% rate increase for providers, so long as the provider agrees to pay no less than $15 an hour to the direct support professional providing their services. And so for us right now, obviously, Alliance doesn't cover Medicaid personal care services. That's still, for us right now, will be on the fee-for-service world. And also Cap C and Cap DA will be kind of excluded from managed care, at least for right now. So while there may not be an impact necessarily on your work today, I just wanted to point out to you that that is out there as a way that the General Assembly is recognizing the important work that these staff do, and wanting to make sure that what they're asked to do is that they're compensated for that fairly. Another version of a direct support worker bill is House Bill 665. And this actually is a continuation, or this was actually introduced in the budget bill last session. This is the piece of legislation that would essentially account for a rate increase to make adjustments for the community ICFs to make sure that they can pay their staff equal rates to what the staff and the state ICFs and the state facilities are making. So because we never got a budget passed last year, that legislation essentially didn't go anywhere. It died with the budget. And so it's been brought up again through a standalone bill this session, which would address that. That's a kind of a smaller sub piece of the total population. So House Bill 914 is the bill that is entitled Support Our Direct Care Workforce. Some of you may already be aware of this, or you may have been asked to participate in kind of a legislative advocacy day 2 Wednesdays ago to support this, or actually might have been last Wednesday. All the weeks start running together. But to support this bill, this is arguably the most comprehensive in terms of the staff that would potentially be impacted by this bill if passed, because it would include Cap C, Cap DA. For us, the big piece is it would also impact innovations waiver, direct care staff, as well as traumatic brain injury waiver, direct care staff. Also state plan or Medicaid personal care services. also the community ICFs. And this takes it even a little bit of a step further with home health staff in nursing homes, and also behavioral health facilities. So staff, direct care staff working in level 3s, level 4s, PRTFs, crisis facilities, and also staff doing inpatient care in some of these substance use facilities. And so what that would do is essentially would it make rate adjustments, and the provider would have to attest that if they are accepting the higher rate, that at least 80% of that rate increase is being passed through directly to the staff's hourly rate, and then the provider agency could retain essentially 20% for the administrative overhead costs related to the staff for accepting the rate. So just again, all of these bills right now are in committee. None of these bills have made it out of committee or to the floor. I think there would be consideration for whether or not these get worked into the budget somehow, or do they stay as standalone bills, like what we had to do last year with some mini budget bills due to the impasse on the state budget. So we're tracking these, but again, wanted to make sure you all were aware that these are out there, because I think this year we've seen some pretty solid effort by our General Assembly to acknowledge and recognize the work that these staff do and kind of the critical state we're in as a state relative to being able to recruit and hire and retain good and qualified direct care staff. So we're watching it, but again, you'll be able to click on the hyperlink and go read directly once these get posted. And then I just have a quick update on HIE, the Health Information Exchange. Kathy says that providers, understandably so, sometimes still have a lot of questions about HIE and what's actually happening. So this bill, House Bill 395, has actually been signed into session law. It was signed into law on May 27th, just last month. And so what this does is it extends some of the timelines for HIE. So for providers of Medicaid and state-funded services, health services, which is you all, the previous timeline was October 1st of 2021, which is right around the corner. And there is definitely an awareness that the state as a system needs more time to process all of this and get things in place. So your new timeline to be fully compliant with and connected and transmitting through HIE based on the legislation that was just passed is January 1 of 2023. So a little bit more time on that, as well as there's a clause in the bill or in the legislation which allows for extensions of time for establishing connection. It's that good faith effort. And so it also extends that. Previously, the good faith effort extensions could not go past October 1st of 2021 as well. And now those are also being extended to January 1 of 2023. So I think those are the most notable aspects of the legislation as it pertains to you all. So I'll stop there and see if folks have any questions. All right. None. I will pass it back to Kathy. Thanks, guys. Good to see you today.
All right. Well, we're going to go ahead and turn it over to Allison Reber, and she is going to give an update and information on our case management agency pilot, the CMA.
Good afternoon. As I'm sure all of you know, part of the tailored plan is moving to a care management model in which every tailored plan member, except those involved in duplicative services, which are ACT, ICF, and high fidelity wraparound, is eligible for tailored plan care management. And this is a big change in the system and one that we are actively preparing for. We have been working with the McSilver Institute from NYU for the past probably more than a year and a half at this point, in order to prepare for provider-led care management, because part of the change in tailored plan care management is moving, not only creating those care management entities, but also moving care management closer to the member and having it exist with the providers. So this is a significant change. As part of that, well, let me move back a second. We picked the McSilver Institute because they were key in helping to develop and train the state of New York, which has undergone a similar process. So they are using that experience and helping us prepare as we move forward. As part of that, many of you are probably involved in a learning collaborative that we've been running for at least the past year to help behavioral health agencies prepare to become CMAs and to apply to become CMAs, the care management agencies. As of yet, we haven't engaged in that learning collaborative with any of the groups to become AMH pluses, which is the advanced medical home for tailored plan, but we are beginning conversations on that. And we developed this pilot to help us improve our planning and to increase our readiness to roll out this model just about a year from now. And so we went through an RFP process, and Monarch was selected through that process to be the organization for the pilot. Next slide, please. So one of the things I didn't put in the slide deck and should have is I want to be clear that this pilot is focused on adults with severe mental illness, and it's Wake County based. That's where the team is based. Our goals were to get experience. We are using that to share information about the challenges and successes with other CMAs through the Learning Collaborative, and then here with you today. We need to learn how we need to support, what does Alliance need to do to support provider-led care management. Those of you who are interested in becoming CMAs, I hope are aware that Alliance is offering the opportunity at either no cost or minimal cost to use our care management platform, Jiva, to address the IT kinds of needs, the data sharing kinds of needs that you have to have as a CMA to support the assessment process, et cetera, et cetera. Needless to say, when you put out an IT solution, even if you've been using it internally, there's all kinds of stuff you need to figure out, and that comes up every day. So this is helping us optimize our use of that platform. We also want to use this to provide feedback to the state about things like rates. How long does it really take to engage people? What does it cost? How big a staff? Things like that. And we will be measuring outcomes, looking at the quality measures, how care management improves performance, and we'll use that as we move forward to help support providers. Next slide. So these expectations really are just what is care management. So the goal is to engage members in their care. There is a required comprehensive care management assessment with with state required elements. And as we all know, as we move into this integrated world, it is no longer a behavioral health assessment. It is behavioral and physical and unmet social needs. All of those things need to be addressed. One of the things I want to point out is that an assessment is not the same. A care management assessment is not the same as a CCA. The goal is care management in the same way the plans of care are care management plans of care. That does not mean that there aren't treatment plans of care. That continues to exist. The expectation is for collaboration and coordination with members treating providers. And again, treating providers means all providers, behavioral and physical. The expectation is that care management is field-based and engages members at sites that are convenient for them, including providers' offices, but not solely providers' offices. And there is also expectation about a 24/7 on-call, particularly for crisis planning transitions. Okay, next slide. So Monarch has built a fairly robust team for this. Part of this relates to the 24/7. You know, as you have more teams, I think there are more ways to spread that around. But when you have one team and small, you know, helping manage that potential burden is important. So they have 3 care managers for what will ultimately be a pilot size of about 100. That's probably a little bit more than you would normally budget for if you could run more than one team. There is, they also have peer support staff on, and that has turned out to be their experiences that is, while not a requirement of the state, is really valuable for, is really valuable for engaging members and addressing members' social determinants of health. They have found their peer support specialists to be very helpful. They have a part-time nurse consultant whose role is to support the care managers around medical needs. They have the care management director is the care management supervisor that's described for CMA, and then behind that, they also have, Monarch is also supporting through QM and IT operations, other supports. We did a soft go live in March. Not surprisingly, when you were putting something new, we had some Jiva problems, we had some staffing problems. So we did a hard go live in May, and it just sort of highlights why you, as with anything new, you always get started early. Next slide. Okay, so what have we found so far? So far, they've engaged about 38% of the members that we have given them. Let me make one other point that I didn't put in here. This is not a program that you refer to. We are assigning people. So it's not something where you can call up Access and say, great idea, let me get my client in. That's not how this is going to work. All clients will have the opportunity next year, but this year we're assigning people to them. But of the people we've assigned, they've so far engaged about 38%, which is slightly better than what the state is anticipating for the first year, which is closer to 30%. They have found that engagement is really challenging. And not too surprisingly, the folks who are higher risk in this population are also frequently harder to engage. And I think that it's that challenges, chaos in lives, lack of stable addresses, lack of stable support systems that make, lead to the vulnerabilities that make people higher risk. Contact information isn't always accurate. They are definitely going out in the community to engage people. They go to people's homes. They think of other places to meet people. They are engaging community settings like healing transitions, about how can they work together. Healing transitions for those outside Wake County is a facility for people with substance use, frequently homeless. Needless to say, they're under 42 CFR, but they are exploring ways that they can work together to leave messages so that members who are willing can contact them, and ways to engage through healing transitions that do not violate 42 CFR, but allow a working partnership. The other thing they found is that engagement is ongoing. Even when people initially consent, they don't always call back. They're not always there for the assessment. They don't always respond the next time. And so it's definitely not a one and done. And tailored plan care management is really for the lifetime that the person is in the tailored plan. It is not a service that ends. And ultimately, our goal is to get every member the support for care management, and particularly some of the folks who are hardest to find. And, you know, ultimately, what sustains this model is a per member per month. So agencies that are more successful at engaging and keeping folks are engaged are likely to have the stronger financial support for the programs. Not surprisingly, people have significant unmet social needs and significant current health concerns. Some of the ones that they have found so far were housing and financial. That's not so surprising, but an important area and an area that we, you know, will definitely need to be supporting members. And of course, with those concerns, it's hard to concentrate on the rest of your health if you're worried about where you're going to stay and whether you have enough money to make it through tomorrow. They've also talked about their variety of health concerns, but some of the examples that they've talked about recently have been folks with uncontrolled diabetes. And one of the stories that I found very moving and wanted to share is that they gave an example of an individual with uncontrolled diabetes, and her doctor had provided her with information, like a bunch of information about what you need to control diabetes, which is, you know, eat different, move more, change what you eat, take your take your blood sugars at regular times. It was completely overwhelming to this person. In the face of being overwhelmed, the person just kind of gave up, right? And so she'd theoretically been educated, but there was no action and the diabetes wasn't improving. What the care managers were able to do was help her figure out where to start and what stuff she felt like she could do. And as a result of this, from passivity in the face of overwhelming, she is starting to take control of her diabetes and doing those steps and moving forward and building on her successes. The result of that is going to be controlled diabetes. The other thing is that a surprising number of folks have been pregnant. Out of the people that they've engaged, something like 5% are pregnant right now. And of course, there are lots of medical needs and unmet social needs associated with pregnancy. The other thing is the need to make sure that people are getting obstetric care, making sure that people who have high risk pregnancies, which most of our members will fall into because substance use and mental health, serious mental health issues are risk factors for high risk pregnancies. So getting people coordinated with currently the local health departments where they do pregnancy care management. So there's all this kind of stuff that we're working through. And the other thing that we're finding is that care management still exists in and will continue to exist in services that people are receiving. So it's for instance, it's part of the CST definition. It's part of supported employment. And the rules are very clear about not duplicating. And so coordinating with treating providers around providing information, making sure that the treating provider is aware of challenges that may be affecting the member's ability to get the most out of treatment, but also in those services where there is care management as part of the service definition, that does not go away. That expectation that this is part of treatment continues, but the care management agency and the treating provider need to have discussions and agree on who's going to do what and who's going to be on first base, and that those discussions will need to be ongoing, not a one and done, to provide the best for the member. Okay, next slide, please. So this is a small pilot and it's in Wake County. and it's adults with severe mental illness. So if the people you serve don't fit in any of those categories, you may not hear anything from this pilot, but these can be takeaways of what you can expect a year from now. If you are in Wake County and working with adults, you can expect maybe some contact from Monarch Care managers about shared members. And it is not something that Alliance would do first. You may hear first from those care managers. We don't always know exactly who is with what service on what time. And this would be ongoing. So as in the future, when care managers would be interacting with providers, that's how it would be now. Transition of care planning and management, that's, as people move from one level of service to another, when that's needed, Monarch Care managers would be involved in that. So that's people moving from hospitals to you and also helping to figure out what's going on to increase hospitalization, coordinating with you and trying to figure out if members are getting ED visits or hospitalizations. What can we do different maybe in the future? What might support the member? But also, as members are ending your service, one of the things that has been true is we have treated longstanding relapsing chronic illnesses sort of one and done. So people finish services and they close down with your agency, and maybe they make it to where you referred them to, and maybe they didn't, right? So as you're discharging, involving those care managers so that they help them get where they need to go next, and improving that gap. All right. Ongoing collaboration regarding care management treatment planning. There are expectations that providers will be involved in that. That could be attending a meeting, but it could be providing information for the care planning meeting. And then, as I talked about before, defining roles and expectations when the service that you're offering is, when care management is part of those services. So Alle had asked a question about a requirement for additional area of CARF accreditation. I actually don't personally know much about CARF accreditation, so I really don't know. You might need to ask CARF. The state will be doing the initial certifications of CMAs and AMHs prior to tailored plan go live. So as people are applying to be CMAs and AMHs, and those dates are for application, there was a date that was June 1st, and I want to say the next one September 1st, but I'm not completely sure. After that, if people apply to become CMAs or AMHs after go live, then it would be Alliance who would do the Alliance or another LME MCO, depending on where you were applying, who would do the certification. But I don't know whether CARF has other additional requirements. Any other questions? Okay, well, thank you all.
Thanks, Allison. I'm sorry we didn't get you out quite on time. We tried. All right. So I am going to, if there's no other questions, go ahead and turn it over to Donna Stevenson. And she's with our the Senior Director of Practice Transformation. And she's going to give talk a little bit about HEDIS measures.
Thank you, Kathy. Good afternoon, everyone. We are going to look at the 3 measures that we are tracking right now or watching as we transition to the tailored plan. There will be many more measures that the provider agencies will be responsible, in particular the CMAs, once we go live. But right now, Alliance is tracking the 7-day hospital follow-up measure, APM, and SSD. So the first measure we have here is the 1 to 7 day follow-up from hospitalizations. This is the state-funded measure. As you can see, our performance is below our trend, where we're trying to benchmark at 40%. We have substance abuse at 32%. And mental health at 27%. So we have been actively working. Our care coordination has to help agencies increase this number. If you go to the second, and I do want to say that the solid line is for the data is from claims that are already paid, and the dotted lines after they hit the mark that we have measured to are for projected forecast. Next slide, please. And this slide is for the Medicaid numbers, same thing, follow up from hospitalization with a benchmark of 40%. You can see the SUD is at 39% and the mental health is at 53%. So mental health is definitely above our benchmark here, but we, again, are having our care coordination team work with members to try to get them into the agencies to follow up from their hospitalizations. Next slide is the next two measures are APM is for children who are on antipsychotic medications to have metabolic monitoring, and the SSD is for adults to have with schizophrenia or bipolar to have metabolic monitoring. You can see that our goal for APM is 38%. The goal is 38%. We're currently at 30%, so we're below 8. We need 8% to hit our benchmark. Our goal for SSD is 82%, and currently we're at 70%. So we need 12% to meet the benchmark for SSD. This data is current through April of 2021. So many of you do receive these monthly scorecards from me. We've engaged a certain a set of providers that get these scorecards. So if you have any questions or comments, feel free to reach out to me about the measures and we can talk about interventions. And the next slide is for those of you who have not participated in the practice transformation session, you can reach out to me, but we do have a Practice Transformation Academy on our website. This is the address. Feel free to go out there. It has lots of information and educational material for things your agency will need to be successful in transforming to manage to Medicaid. And if you have any questions about any of it, again, feel free to reach out to me. Are there any questions? Okay, thank you everyone for your time. Back to you, Kathy.
Thank you, guys. So the next person, I know we go through these. This is where it's just so hard doing it virtually because it's, can't see faces, but we'll go ahead to the next thing on the agenda. And Matt Ruppel from our compliance, he's our director in our compliance department. And he is going to talk about some non-Medicaid funding eligibility.
Thank you, Kathy. I wasn't sure if I was unmuted. Thank you, Kathy. Good afternoon, everyone. I'm here to, as Kathy said, here to talk about non-Medicaid eligibility. And as a reminder for everybody, we're all obligated to ensure that the limited non-Medicaid funds are utilized to support individuals that do not have any other resources to pay for those services. A couple of years ago, we conducted a review of the eligibility determination processes that were being followed across the 4 counties we're responsible for. And we found quite a varying degree of information was being collected and utilized. In some cases, not very much. Some providers are doing a great job with it. But because we found it was so varied, we decided we needed to update the provider operations manual to make it more clear what the expectations were. So we completed that update and was posted in the October 2020 manual. You can find the full details in section 7. And here's some of the requirements here on this slide. The providers are expected to conduct an initial and annual, at least annual confirmation that the members do not have some other resource such as private insurance, Medicare, Medicaid, or health choice, and also the ability to pay on their own, or do they have assets or anything that might help them pay for the services. Proof of household income, verifying county of residence. Again, a lot more details in that section 7 of the manual. And we can go to the next slide. So one thing that we expect providers to do is first to ensure that you do have procedures in place that are consistent with what the expectations are, what the requirements are. If you have not reviewed the operations manual, strongly encouraged to do so. Look at that information and update your procedures. Make sure that you're doing everything that's required to make sure that this funding is being utilized in the correct way. We do encourage self-audits. If you do identify an overpayment, you are required to report that to Alliance so that the money can be refunded. And we also have procedures in place to conduct audits. We will be conducting random audits in the coming months of providers, and they may be incorporated into other reviews that we conduct to ensure that this is being done correctly. And of course, any reimbursements for services for members that weren't eligible could be subject to recoupment. And that is everything I have. Any questions?
Great.
All right, thank you.
All right, thanks, Matt. All right, so want to go ahead and turn it over to Christina Phillips. I don't know if Mike is joining us with the presentation, but just to go through some reminders for EVV. Go ahead, Christina.
And actually, Mike will not be joining us, but just wanted to take a few minutes here just to remind folks where we are right now with EVV. EVV stands for Electronic Visit Verification. It only impacts certain services. But where we are right now is we are going live June 30th, and that is the state of North Carolina. Services under the LME MCOs are going live June 30th. Next slide. So some folks, I'm sure everybody's very aware, what is EVV? It's a federal mandate that the CARES Act, the Centers of CMS does require that states begin utilizing electronic visit verification for a number of select services. And here in North Carolina, we're looking at the NC Innovations waiver, TBI waiver, and select services on B3 services. It is not all services on innovations and TBI waiver. It is very select and specific services. Next slide. So some folks are wondering if you've heard that term EVV, what is it? EVV uses technology to record the times, dates, and specific services that are given. And really what this does, it helps to make sure that people who should receive the services in fact do receive them. Next slide. So again, you can check on our landing page. We do have our EVV landing page. These services do impact TBI waiver, specific TBI waiver services, specific innovations waiver services, and B3 services. And we do have that matrix listed on our EVV landing page. Next slide. So one thing we're asking anyone that is an EVV provider, you have looked at the service matrix and you've determined that yes, indeed, you are an EVV provider. We are asking that you make sure that you're signed up for provider news. And of course, that little orange button there on our website allows you to sign up for provider news. All information and all updates regarding EVV are being sent through provider news. So it's really important to check that. I just saw in the chat box, there was a question around relative as provider and the codes coming through for that. We are actually still waiting guidance from DHHS at this time, and we will be alerting providers through provider news as soon as we have an update from the state. So it's really important to watch that provider news for updates. Next slide. So one thing, again, we want to point providers to, if there are questions around EVV, we do want to point you all to our landing page. You can just simply type in EVV and our landing page should come up for you. It has all the information, background information on EVV, trainings, links to trainings, webinars, everything that you should need to launch your provider agency to make sure that you are becoming EVV compliant. Next slide. So again, we want to bring home the really where we are at right now and the important next steps for your provider agency if you need to be EVV compliant. Next slide. So what we're doing right now, there is a really large push to get to the home stretch right now. So we're 15 days away approximately from EVV go live. This is a statewide initiative. We are working in partnership with the state. Our selected vendor is HHA Exchange for Alliance. And what we're hoping to do, whether you're considered what we call an EDI provider or a non-EDI provider, all providers will need to integrate with HHA. And what our ultimate goal is to confirm end-to-end testing being successful. So we are in the process right now. If providers are ready to send their first production files, we stand ready to receive those. We'll be working directly with HHA in our IT department. And at the very end of this PowerPoint, we do have the mailbox where you can send confirmation that you are ready to submit your first production files. So we hope that you have read the information, gotten your teams up to speed, and are ready to confirm end-to-end testing at this time. Next slide. So just as a quick reminder, EVV language will be going out into your FY22 Alliance provider contracts. And again, once finalized by DHHS, and that has not yet been finalized, all EVV related codes will be added to Alliance provider contracts. So we are waiting finalized word from the state right now on those additional codes. Next slide. We want to make sure providers feel supported. And so we've listed here the different technical assistance support centers you can go to. Of course, you can always turn to provider EVV at alliancehealthplan.org. We're receiving and fielding several emails through that mailbox right now. If you are stuck on any step in terms of readiness, you can email us there and we can connect you with HHA Exchange directly or directly send you to their support desk. There is an NC support at HHA Exchange address listed there. We also have our landing page listed along with the state's landing page. So there is a lot of information here on this slide. If you need technical support, please utilize this last slide. Email us at provider EVV and we will help direct you to the right place. Next slide. Again, we just wanted to hit home that the best place to submit your very specific EVV provider questions are provider EVV at alliancehealthplan.org. We do have a team standing ready to assist you. We are doing our best to get through those emails as quickly as possible and respond to all the questions coming in around EVV. That is your best source and the best place to submit questions to. So hopefully that's helpful, Kathy. Are there any questions in the chat that we can answer right now beyond anything around the state codes?
There's no other questions listed at this time.
Yeah, there's one question.
Oh, is there?
There's one. It says, are there codes and processes in place yet for individuals who have relative as provider as well as staff subject to EVV?
Right, so relative as provider will be exempt from EVV and we're working with the state on what that finalized code is going to look like. We are hoping to have information from the state later tomorrow. Again, watch provider news. It's going to be really important to keep an eye on provider news around EVV information. It's coming quickly and we will make sure to update the providers through our provider news updates.
Great. Well, thank you very much, Christina. I think that was perfect, helpful. So Amy, if you can go to the next slide. So we are actually at the end of our meeting. People will get a potential half hour back of their day. So just wanted to, if you have any other questions or things that come up, please feel free to contact your provider network development specialist and put the link of, if you click on listing, and it's on our webpage too of who everybody's provider network specialist is, or you can always email the provider network help desk and they can get your email to where it needs to go. So just want to say thank you all very much for your time. It's a beautiful day. It's not humid out there today, which I was able to get out for like 10 minutes at lunch. So enjoy the day if you're able to. And our next all provider meeting will be in September, which seems so far away, but it'll be on us pretty soon. And we'll see how everything has gone with the standard plan transition and any other news we have about the realignment with Mecklenburg and with Orange County, et cetera. And any other questions that popped up after our folks that did the presentation finish the presentation, we'll go back and we'll put the question and answer on the webpage. So when we post the training. All right, guys. Well, thank you very much. Have a wonderful day.